Uh, Dear students of batch 21, uh, welcome all to year 5. And I think this is the first lecture from my side. We're meeting for the first time in year 5. Okay. Uh, so as the MCO is in place and the objective is, is being achieved. We are the number of cases are getting dropped from significantly from 3 digit to 2 digit. So we hope so that we would meet soon. Huh? Don't worry. So we will be back very soon, and then we will continue with your learning until then. Okay, fine. Today we will see about the the next part of the impaction, which has been already discussed by Dr. Sendil. I think you people would have heard the video of, seen the video of dealing with impacted mandibular teeth. Okay, today we will see the next common variant of maxillary impacted teeth. Okay, um, essentially all the steps of managing this teeth remains the same with a little bit of differences by the virtue of their position in the maxilla. Okay, fine. So the learning outcomes stays the same as for the previous lecture. You should know about when to do it, when to not to do it, and then you should assess the degree of difficulty and the various surgical methods, and of course you should be aware of the perioperative and postoperative complications so that you will take every step to avoid it. Okay, fine. It goes with like any other treatment. We have to clinically examine it, and then we have to radiographically evaluate it, and then the classification is for our convenience sake, and then we should employ the appropriate surgical technique. Just like the mandibular, you have here the same mesioangular, distangular, vertical, horizontal. All these things are there, and again, like the mandibular teeth, you have to the relative depth have to be studied. Um, of whether it is in position A, B, or C, depending upon the varying levels of occlusal plane with respect to the second molar. Only thing the difference is that what are all the factors which will favor for easy removal of tooth in mandibular. Here, there it will be opposite to that. Say, for example, if there is a mesioangular tooth which can be very easily removed in case of a mandible. Here, mesioangular tooth is the most difficult one. This triangular tooth is the most easy one because of its position and then the easy path of withdrawal. So like that, there are some minor differences. There we will be worried about the close approximation of the inferior alveolar nerve in case of mandibular impacted teeth. Whereas in maxillary impacted teeth, we are going to be careful, and then the proximity of sinus floor is going to worry us. Like we have to be very careful with this. Okay, to prevent oral communication. Okay, fine. So these are all the major, little bit of differences. Then we will go through the lecture, and then we will learn one by one. So clinical examination, to look for pericoronitis or dental caries, and then you should get the history of present illness and medical history. When on clinical examination, I suggest is that whenever a person is coming with pain in the lower jaw, never orient your examination only towards the lower jaw teeth. That is, uh, especially in cases of third molar region. Do observe, do take time to examine the opposing antagonistic maxillary third molar as well. Because many a times, if these mandibular third molars which are impacted, which have not surfaced itself, which are bony. I mean, it is having there is a bony impaction in the mandible, but the buccoverted or the distoverted position of maxillary third molar, um, it may lead to trauma from occlusion, which means that the sharp portion of that impacted tooth might come in contact when the patient is masticating, and then they will cause a repeated ulceration in the lower jaw, which is the reason for pain. So if you are addressing only the lower jaw impaction, that is the mandibular impacted teeth, and then leave as such, it is not going to resolve uh, the the situation. It is not going to address the problem of the patient. In case if you are seeing that the patient is coming with a complaint of mandibular impacted, I mean the pain in the lower jaw, if you are not so sure about whether there is really a teeth or not, because you are examining and then you are feeling that the tooth is the mandibular third molar is deep inside, always look for examine the uh, opposing maxillary third molar also, because it may give clue to the uh, your diagnosis. Okay, many a times patient will feel much free or symptom free. They will see resolving of their complaints only with the removal of maxillary third molar, which has been the uh, mm, cause for that mechanical problem. Okay, fine. So what are all the factors which we have to consider during the removal, which may give you an idea of about how difficult your extraction is going to be? If the patient is having a small mouth or retruded mandible, or mouth opening is small, and with the presence of lymph nodes which may indicate an infection, and palpable and tender lymph nodes. All these things will decide the accessibility of your of the impacted third molar. So have an idea of all these things, and then we have to proceed so that we can take appropriate measures to avoid injury to the adjacent soft tissues during the procedure. Okay, so intraoral examination, you have to examine both the hard and soft tissues here. Of course, the nearby ulceration or the soft tissue swelling, how healthy the surrounding tissues are. Okay, fine. Then we have our radiographs, of which IOPA also, is of much value in studying an impacted tooth. More than an OPG, more than an occlusal, IOPA is of much value, and then it is with low cost, low radiation, and then you get to you obtain the picture which you actually want to study in an IOPA. So much of the information can be derived from IOPA rather than the OPG or a CT scan, if we are carefully studying the X-ray properly. So IOPA is still the best technique to study an infected tooth. And then, of course, we have an OPG to know whether there is an associated cystic formation or anything to study extensively. And then we have the occlusal view, and then we have the CT scan view if you want to know exactly the position of the impacted teeth. So the tube shift method, I think you people have already studied in year 4 to know whether the impacted tooth is labial in position or palatal in position. So you are shifting the tube, and the unerupted tooth moves in the same direction that it is located on the lingual side. But if it is move, but the tooth, if it moves in the opposite direction, the tooth is the tooth is placed more buccally. Okay, this will help us to decide from which side we have to approach, whether from the labial side or palatal side. Okay. So these are all the pictures of various uh, radiographs. You have OPG, you have the occlusal view, and then you have the IOPA view. See, all this gives the uh, idea about uh, where the impacted tooth is. So among the classification, you have the position A, B, and C. Just we had the classification in mandibular third molar with respect to the occlusal surface of the impacted tooth in relation to the uh, second molar. So the second molar cervical line is the determining factor here. So accordingly, the position A, B, and C have been marked, and then which indicates the relative depth, okay, how deep the third molar is, which indirectly tells us how much of bone we have to remove. Okay, say for example, as you seen from the picture, position A, we might not need much removal of bone, but position B, C, and the DE, which are very, very rare, so we might need extensive removal of bone. Okay, this is helpful for us to plan the surgery. And then the angulation, of course. The reference point is that the long axis of the second molar. The long axis of the second molar, how angulated the impacted molar is. So accordingly, you have this, when it is tilted towards the mesial side, it is mesioangular, distal side, it is distoangular, vertical, horizontal, buccoangular, that is towards the buccal side, and lingoverted or inverted. All those possibilities uh, uh, we are studying here. And then as you see, the distoangular impacted teeth in maxillary molar is much more common. Okay, so as I've told you before, the distoangular impaction is much more easier than the mesioangular impaction, owing to the amount of bone that has to be removed. Okay, fine. Then again, as is intra-alveolar nerve bundle for the mandibular teeth, sinus is for the maxillary teeth. So we have to know whether the tooth root is in close approximation with the sinus or not. How close is it? It is. So when there is a sinus approximation, which means that there is no bone or only a very thin bone that exists between the impacted teeth and the floor of the sinus, which means when you are going to remove this impacted teeth, there is definitely going to be a oroantral communication. Okay. Then next, when there is no sinus approximation, when there is at least 2 millimeter of bone or more which exists between the floor of the sinus and the impacted teeth, which in case, which means that in first part, that is sinus approximation, oroantral communication is unavoidable. In second part, you are not supposed to create any extra communication. Okay, you should be very careful in removing the tooth, and then with no encroachment into the floor of the sinus. So these things we have to know. So this is the, see, look at that impacted tooth, which is very, very close to the maxillary sinus. Sometimes they say that the tooth root itself will substitute, it can contribute to the part of the posterior wall of the sinus. It is that close. So this, especially, you should look for in elder patients. Okay, elder patients, the pneumatization of the sinus is more, and then uh, especially when the tooth is impacted, there is a very chance that there is sinus approximation between the third molar and the maxillary sinus. So what are the factors complicating the removal? Of course, first, how close it is with the sinus, and then how close it is with the second molar. This is very important because, see, this is something which differs from the mandibular third molar, because as we do the guttering in the mandibular third molar and try to elevate it, the second molars will not always be, I mean, uh, the second molars will not come in interference. So if it comes in interference, we will split the tooth into two and then we are going to take it out. But here, depending on the position of the maxillary molar, the elevators which we use, if they are injudiciously placed or injudiciously tried, if you are giving undue force on the maxillary third molar, it may affect the second molar because it is in close proximity, number one. Number two, the accessibility is very, very limited. Only the operator can see where he is placing the elevator. Even the assistant will not be able to see what the operator is actually doing. He will be arbitrarily guiding and then giving the section, putting the section, and then he will be assisting in the procedures. But only the operator knows where he is exactly placing. And moreover, you see the maxilla bone, which is very, very soft when compared with the mandible. So there is every chance that the the second molar may get affected very easily. Especially, you be very careful when these second molars are involved in FPD. hmm, They are taken as abutment for the adjacent, I mean, bridge. So this is the potential area for litigation issues. The patient might go to court because if you are manipulating the third molar and then if you are damaging the second molar which has been already restored with the crown or with the FPD unit or with an onlay or whatnot. So when you create damage to those, so it may affect the masticatory ability of the patient. So this is a potential area for litigation issues. So you have to be very careful in saving the second molar first. Okay, fine. Then especially when there is fusion of root with the second molar, you have to be careful, and then you have your own techniques to remove without causing much damage to it. And then unfavorable root curvature, which will cause intraoperative complication of root fracture during the treatment, and then increase the bone density. As the bone becomes more and more dense, it will not give way for the impacted tooth. I mean, when you are applying the force, it may not give way for removal, so you may have to manipulate it very carefully, and then it may take more time. And then of course decreased mouth opening, especially in maxillary region. If the patient mouth opening is very less, then it is going to complicate the procedure because already the accessibility is very less. Then when there is decreased mouth opening, it is still less. And then you are going to work in an extremely confined and small area. So which will very easily complicate the removal. The thing is that you will, out of your zeal, you will overstretch the tissues, and then the patient will complain of tissue edema postoperatively. The patient will have difficulty in mouth opening, and then the entire area of cheek will appear to be swollen because you will be unknowingly manipulating the soft tissues um, a bit harsh because you want to have the access. So in such cases, the patient will complain with postoperative swelling, edema. So we have to be very careful in handling the soft tissues as well. Okay, fine. These are all the ways by which we do it. Just like what we do it for the mandibular, you have this flap rising first. You have to raise the flap, and you can have the triangular flap for better accessibility rather than the envelope flap. Okay, this is a pictorial representation. So you have this envelope flap, and then you raise the mucoperiostral flap. Again, remember, when you are retracting these flaps, make sure that the free end of the elevator always rest on the bone, not on the soft tissues, which is something which you have to be very careful when you are operating in the maxillary area, because already you will not be able to see what you are doing. So make sure, double check whether the free end of your elevator, I mean retractor, is on the bone. Okay, fine. So these are all another types of incisions which can actually give a good access. So look at the incision that has been placed inside the mouth. Much of it you will not be able to see, but see, there is an anterior releasing incision, and then they have placed a crestal incision over the impacted tooth region. And you raise the flap. See, then again look at where the retractors have been placed, and then see there we are able to see a portion of the small tooths uh, which is impacted, and then you are able to see that. Many a times you can use this Warwick James elevator or Cryers elevator to take this out, and then the tooth is gently lifted, elevated out of the socket, and then it is taken out. Make sure, so this is one important thing when you are doing it in the patient. um, the thing is that when you are attempting to remove that impacted tooth, it stays the same for the buccoverted maxillary third molar, which may not require surgical removal. Many of you would have been will be extracting the maxillary third molar mean patients with maxillary third molar with bucco-verted or distorted teeth. So when you are attempting to extract this, elevate this maxillary third molar, ask the patient to half close the mouth. Ask the patient to half close the mouth. It will not hinder your access. Of course, you will see only very little, but once the patient closes the mouth, okay, the coronoid process goes back, and then it gives more room for the tooth to be extracted to come out. So when you ask the patient to open the mouth maximum and then trying to elevate it, you will have difficulty because the coronoid process is coming in and hindering the removal. So I think you are able to imagine it. Okay. Anyhow, when we are actually extracting the teeth in the patients, I will teach this again to you, like, when I'm standing chair side. Okay. Fine. Just keep this in mind when you are extracting the maxillary tooth. When you are doing the path of removal, when you are delivering the tooth out, ask the patient to half close the mouth. Okay. So, yeah, suturing is done. Suturing is done. So suturing is a bit challenging because of the accessibility issues. It's not as easy as in the mandibular region because it is straightforward in mandible. Whereas in maxilla, it's a bit challenging because of this accessibility. You have to go and suture in the remotest part. So what are the associated components? You can have this laceration of soft tissue flap or fracture of the tuberosity. Fracture of the tuberosity is something which we have to bear in mind because it does happen. I mean, it can happen when you are giving undue force. So with the normal force of elevation, you see some difficulty in the removal of the teeth. You better be careful, take time, and then remove it. Don't be overzealous. Don't try to push the tooth backwards. Don't try to use the elevator like rowing the boat. Okay, you have to use the elevator with the wheel and axis. Just you have to rotate the elevator just like you would open the door with the key. So you cannot row it. I have seen many students started using that rowing action. So you cannot do that. So because in case of such undue force from the elevator has been delivered, there is every possibility that the fracture of maxillary tuberosity might happen. So especially in this era of implant, to your zygoma implant, pterygoid implant, all these things. So your tuberosity should be very well preserved. Okay, fine. So the complications related to the adjacent structures, of course, we have seen much about the maxillary sinus, and then swallowing of an impacted tooth with general anesthesia is very very rare because when the patient is taken up for the oral surgery in general anesthesia, first what we do is the throat pack. Okay, so the tooth will never escape beyond the throat pack, but there is a chance that the tooth would escape into the adjacent areas, infratemporal fossa, this like things like that. So we have to be careful with this. Okay, fine. So the post-operative complications, like we would say that 0.13, 0.12, and 4 are inevitable outcomes of surgery rather than calling them as complications. So any surgery for that matter, it is associated with pain, it is associated with trismus, and then there is some pain at the TMJ, limitation of movement, but don't take it for granted. When they are present for a long time, then there is something wrong. So when the patient gets operated, the second day the patient comes that I have pain, I have swelling. We have to convince the patient that these are all the inevitable outcomes of surgery. But when it is persistent for beyond the third day, continuing in the fourth, fifth day, then we have to be worried about what has really gone wrong. Okay, and we have this pain on swallowing due to edema of the pharynx and hematoma formation. This is because when when we are not sorry when we are not handling the soft tissues properly. Okay, fine. So we will come to the next. Other than the maxillary impacted tooth, we will come to the next most common impacted tooth, which is canine. But unlike the mandibular and maxillary third molar, we don't do it customarily in our clinic, but occasionally, sporadically, we get one or two cases for every 6 months or something. So I think there is a video that has been put up in our e-portal. The case has been done by Dr. Kamaraj. I think there is a video which is already available. So if you want to know actually how the procedure will happen, if you want to see, then you can click onto the e-portal and then watch the video first. Okay, right. So the canine which erupts has the longest path of eruption. Almost it has to travel 22 millimeter during its course of eruption. So the longer the period of development, the more chance for the canine to get impacted. Okay. So because of long path of eruption, because of already presence of crowding, and then when the residuous, I mean retained deciduous teeth, the it is not resorbing, the root are not resorbing, and then there is a repeated trauma which results in scarring of the tissues, which can all cause to the, which can all lead to the canine to get impacted. So it may be linked to the tooth arch size, arch length, and sorry, tooth size and arch length discrepancies, which will say that the tooth is bigger than the arch, so it is not able to come out, and then it is not able to position itself in the arch. And then there is when there is a prolonged retention of primary teeth, and then there is the tooth bud itself is abnormally positioned, and then there is a presence of a cleft or ankylosis of deciduous teeth. Of course, the rarer cystic and neoplastic formation, and then when there is a dilaceration of root, all these things can cause the can hinder the eruption process of the canine, and then it can get it will stay somewhere inside the maxilla. So, how to classify? Again, we have only two jaw, maxilla, mandible. If there is a canine, it should be only in these two jaws. So there is maxillary canine impaction, mandibular canine impaction. Again, the position is how whether it is placed buccally or palatally, which in turn will help to help us to decide what is our approach of removal, whether we are going to go from the buccal side or palatal side. Okay, fine. We have the various classes depending upon the position. You have this horizontal which ranges from class 1 to class 4. Okay. Uh, Here the more than the angulation, with respect to canine, more than the angulation of the canine, which is not of much important to us, the how deep it is the important factor. Okay, fine. So diagnosis is by examination. So you have can right from the extraoral examination, you should look for all these features like relationship of the midline, and then overjet and overbite, and whether there is any delayed eruption of primary permanent canine or not, and then there is any retained residues or not, and then to look for any bulge in the labial side or palatal side. Many a times when the tooth is according depending on the position of the canine, there will be relative bulge on the that can be palpated when you are examining, especially when there is a I mean missing canine. Okay, then there is a whether there is a associated delayed eruption or tipping of the lateral incisor. All these can contribute to the impacted maxillary canine, which means that the canine's eruption is hindered by many of these features. So you have this radiographic diagnosis. You can have periapical, occlusal, extraoral techniques. Of course, we know that the slop technique, that same side lingual and opposite buccal, which effectively we can know how deep the canine is, labially or palatally. When you should extract, what they say is that when the orthodontist predicts the possibility of the tooth which can be extruded through their guiding wires, guided eruption, always go for that, because you can avoid a surgery. All that is needed is that you have to expose the crown, and then to give sufficient tuck in the keratinized mucosa to give sufficient room for extraction, and then for extrusion. I'm sorry, extrusion. And then if you leave it to the orthodontist will carry out this his regular etching procedures and start applying the band, and then he will carefully guide the canine towards his position. So this is an assisted guided eruption. Always go for it. Only when the orthodontist say that this canine cannot be um, brought down, or there is no use in bringing the canine, so then only we go for extraction of the surgical removal of the impacted canine. Okay, so this in case of when it is ankylosed, or if it is undergoing internal or external resorption, or the root is severely, if it is jeopardizing the planned orthodontic movement, mm, and because of any occlusal abnormalities, and of course we should not forget that pathologic changes are much more common associated with cystic formation. Okay, fine. So this is extraction of canine using of a labially impacted canine. So you can see the canine from the OPG. You can see it from the clinical picture. Here you cannot see the bulge actually when you are. This is a palpatory finding. So when you can palpate it, you can feel the bulge. Just like they are doing an episectomy procedure, they have placed an incision, and then they have carefully reflected the flap, and then I think you can see in the clinical picture after the flap is raised there is a slight bulge that is apical to the lateral incisor. Just note for it. Then they have made the guttering, they have exposed the crown. So just because there is a canine which is horizontally positioned, you should not expose all the way to expose the entire tooth and then you have to take it out. No, it is not like that. It is a saying that the bone belongs to the patient and tooth belongs to the doctor. So whenever you are doing an impact tooth, so attempt at minimal bone removal and then try to segmentalize the tooth. Odontotomy procedure, which cuts the tooth piece into two, and then you can take the tooth in piecemeal. So you can take it piece by piece so that extensive removal of bone is not required. This is of much importance, especially in terms of in the era of implantology. Okay, fine. So see the tooth is being cut into two. See they have kept the burr is being split into two, and then it is being removed in piecemeal. Removed the crown portion. Now they have removed the root portion remains inside. The root portion is taken out with an elevator with and purchase point already created. You see that is being marked in the arrow. There is a hole there which is a purchase point to scoop out the root which is already inside. The root is taken out, and then the follicle which is surrounding that area is also taken out to prevent any neoplastic formation. It may appear very small to you, but this is very important. You have to use it, and then you have to, if you are finding it any soft tissue covering this impacted canine, you have to definitely scoop it out and see to that only hard tissue remains there to prevent cystic formation. Okay, there is a risk in that. So this is how the tooth which is being extracted and then the operated site appears. The area is washed and then it is sutured, and then we are seeing that canine with partial bony impaction. As soon as you raise the flap, the canine you are able to see it, but there is no point in bringing the to the occlusal relationship because the position is abnormal. They have removing the bone. They are just teasing it out. Here there is no need for any tooth splitting. They are attempting to tease and then the entire tooth is taken out. The area is sutured back. So now there comes a most difficult, relatively difficult, especially when the tooth is placed palatally. Palatally, you will not have such a free hand of elevation of flap because the palatal mucosa is very thick, and then you cannot do stripping of the palatal mucosa as and when you like what we did for we can do it in the labial side. No, this mucosa is not so forgiving, and then they are very stern. It should be stern, so you should not prevent excessive um, of stripping. With minimal access, you have to operate, and then you cannot place the incision on the rugae and other things. Okay, yeah. There is pictorially represented here. So they place a clavicular incision, and then they carefully dissect the and then expose, raise the flap, and then expose the. This is the area in which we are going to operate. We have to be very careful regarding the incisive foramen, which is located just behind the central incisors, which we cannot injure that area also. So be very careful. So they have exposed the canine. The crown is being exposed, round burr, and then again, this what it has been told. We are doing this. So here, um, splitting of the crown into two, odontotomy procedure is being carried out. And then, see, when they are splitting the tooth into two, they don't take the entire length of the burr and then cut the. They don't do until they cut into two pieces. You can just do the odontotomy procedure. After you have reached a particular sufficient length, when you insert the elevator in the gap and then twist it, the tooth will automatically get split. It is not necessary that you have to go entirely into the root and then you have to divide the entire tooth with the burr only. No, it is not like that. Okay, fine. So it is being split up and taken it out. Yes. Purchase point creation, and again teasing the remaining root portion out. See, there is a severe dilaceration. Probably this is the reason why this tooth has got impacted. It is not able to come to the proper course. So this is the operated area. Okay, irrigated and sutured back. This is an ectopic canine position. This is again possible. See, look at that. The tooth is almost in the nasal floor. It is protruding inside the nasal floor actually. So removed this approach, just like what you do it for the Caldwell look approach. I think you people who have already finished surgery, so general surgery, so you will know what is Caldwell look. It is like opening a window in the anterior wall of the maxillary sinus. See, they have placed the incision exactly like that. So they have going into the canine fossa region, and then they have raised the flap, window there, and they have created a window. The wall is being opened up, tooth is removed because it is near the nasal floor. The tooth is removed. The wound is sutured. This is which is the most conservative way of managing an impacted canine. When there is a possibility of the canine to come into the oral cavity, the orthodontist would help you in doing this. Okay, so always this kind of impacted teeth you discuss with your fellow colleague orthodontist, and then you proceed with the case, because when in that case you can avoid surgery in the patient. A patient also will be very happy because he is having his own teeth, like instead of taking it to the surgery and then doing it with managing with premolar canine, is the patient will be having his own, so he will be very happy when you avoid a surgery, if it is possible. So see, the area is being exposed, the canine is being exposed. Yeah, see, all these routine etching procedures have been carried out, and then the brackets are placed on the labial surface of the canine. So depending on the traction force, this canine can be guided to the uh, proper position, the position of their in the arch length, in the arch. So what will happen when you are not removing it? So it can cause the malposition of the neighboring teeth, migration of the neighboring teeth because of lack of arch length. It can cause internal resorption, or it can undergo the cystic deformation. So the neighboring tooth root external resorption is also common, and then when it is partial eruption of the canine, infection is also possible. So it can also give rise to referred pain, and then it can then sequelae of not removing an impacted tooth can give rise to all these problems. So this is just to show you the picture of how far extensive or how traumatizing when you are overzealously extracting the maxillary impacted tooth or maxillary teeth for that matter, when you are using then um, extremely violent force to take it out. See, the tooth is given, the tooth is taken out along with the maxillary tuberosity. Now, it doesn't stop only with the maxillary tuberosity. See, they have lateral pterygoid plate, artery to the lateral pterygoid, everything has come out. When we do such cases, they are definitely they will go to court. Okay, when you can avoid this possibility, then you have to be very careful in giving. This is just to give you an idea of how careful you have to be when you are using your elevator, because elevators are very strong instruments. When you the amount of force that you deliver at the end multiplies, multifoldly increase when it is delivered at the tip. So you have to be very, very careful. Okay, fine. And if you don't want to extract with all these methods, in this way. Okay, okay, fine. So um, have a nice day, and then you post your doubts in the Google Classroom if you have one, and I would look for some questions regarding this topic, and then I will post it. You will have 1 week time, and then you can answer them. Okay, have a nice day, stay safe, stay home. Hope We hope and pray that we will meet soon, very soon, because this is an impaction topic. We cannot learn much more by theory. You have to actually see it. So watch the video and then learn the relevant points, and then we will be in touch. Okay, bye bye, thank you.